disease. This is the James Reason theory of Swiss cheese, adapted by McCain. Is a kind of theory that you could do a risk assessment. And here we can see some layers of cheese. For example, physical distance, ventilation, mask, hand hygiene, testing, traceability, and surface hygiene. Using James Reason model, we can see that if any of the measures fail, the barrier weakness. Therefore, throughout the whole process of flying, we have to take into account every single one of them. First, for example, testing. If you want to enter Argentina, if you are Argentine, you need a PCR test or quarantine for 14 days. But foreigners, you need electronic affidavit completed within 48 hours prior to boarding, PCR test and negative result, and also a health insurance. What happened at the airports nowadays? Now I will show you some photos of the Argentinian airport in which you can see the measures taken. For example, you can observe the acrylic screen, if it's used when you can be at a proper physical distance, less than 2 meters. You can also see a sanitizing station with a movement sensor. The system expends alcohol to wash your hands for free. During the check-in, you have also a screen here at the counters, signals for maintenance of distance, and physical distance between passengers. Only people with boarding pass can enter to the airport locations nowadays. Another thing is shopping. Shopping is always a nice activity during flight waiting. So sellers have to be updated with prevention measures, such as sanitizing mats here, signage on the floor, for example here, provision of alcohol with a pedal, so you don't have to touch the equipment. In the case of the Starbucks, we have here closed seats, and they have different ways to enter and to exit so that people do not face each other on the road. In the process of boarding, you also have here closed seats and acrylic screen and mask. And here at the bottom, you can see that the distance is not maintained. When the crew checks your boarding pass, you can see that the screen is not protecting here both people because it's not on the correct position. The screen is on the front, but the passenger goes on her left. So here we have the protection, but it's not correct in the position for protecting in a right way. On board, you have here, you can see the passengers. The recommendations for passengers are not carry hand baggage or one at maximum. This luggage can only be touched by the passenger, reducing contact with the crew. People can walk during the flight. The only permission to stand up is for going to the toilets. And it's not possible to leave seats free for economic reasons. Here you can see all seats completed. It's a problem, but it's not a big problem, sorry. It is recommended also that passengers not eat or drink at the same time, just to have their mask worn, at least one each. The food is given packed at the entrance of the airplane or during the flight. And now, the disinfection, that is a big question nowadays. The disinfection is done with an electrostatic fogger. This one, and here you can see it. In this way, its microparticles are more easily inserted into any micropore and adhere better to surfaces, included seat fabrics. All the fabrics were a problem, but with this electrostatic fogger, the disinfection is almost complete. Furthermore, as it works with a battery, the quaternary ammonium, that is the disinfectant, has an effective effect in the fabric and in all the surfaces, like tables and other equipment. It is applied before the departure of a flight and is left to act for 10 minutes, so the disinfection has enough time to complete. The other is about disinfection again, and the product used is quaternary ammonium, and the droplet diameter is almost between 40 and 80 micrometers. Something that is important is the product has to be appropriate for the structures and materials of the airplane. We can't use, for example, bleach. We have to use a compound that not damage the structure and the materials on the airplane. Another point that people always ask is ventilation. You here can see that fresh air circulates from the cabin ceiling to the cabin, pull it from the bottom section and send it to the HEPA filters and outside. The aircraft receives external air, in number 1, through the engine. Then the air conditioning system adjusts the compressed air to an appropriate temperature and supplies the clean air throughout the cabin. In this video, you can see it more clearly. Well, now with this brief explanation of the measures taken, are you still worried about flying? The link is the same as the other slide, and we want to know what is your opinion now after this explanation. Oh, it's maybe 50% of you are more confident in flying. Not okay. Well, 50-50 it's a good result. Thank you. If you have any question at the end of the presentations, I will be pleased to respond. Thank you.
Thank you, Maria Fernanda, for your wonderful presentation. I'm not worried about flying now by hearing your information. So with this, I'm pleased to welcome Dr. Amit Arjyal from Nepal to share his presentations. So over to you, Dr. Amit.
Thank you, Sabina ji. Let me start. So, I decided to take a slightly different approach. So rather than what advice is given to travelers, I decided to talk about traveling during the restrictions that were imposed due to COVID-19 throughout this year. So this is the new determinant of infectious diseases. We are used to talking about clean water or dirty water, housing, poverty as determinants of infectious diseases, but air travel is the new determinant and applies to COVID-19 as well. Luckily in Nepal, we have only one international airport. The second is still to be constructed, completed, and the second airport was due to begin construction in 2016, the large international airport, but factors haven't worked out and work still hasn't begun. So we're lucky in that regard. But the very factors which prevents work like that to be done also prevents work like having a doctor, a paramedic, or an airport help desk that is fully functional in a country to be done. We had an airport health desk during the time of the Ebola crisis, but then it was not continued after that. And it's not easy to have a help desk where you can just screen travelers who come into the country, because there are many factors to consider. For example, if you just screen for symptoms, will that be sufficient? People might be incubating the illness, or if you gather information, what information will you obtain? How will it be recorded? Once it's recorded, will you be able to retrieve it when you need it? And you can educate and counsel travelers about what they should do and why, but when you tell them don't meet people including family, or don't travel unnecessarily in the country, or be in touch with health institutions if you're sick, will they comply? So these are the issues. There are managerial issues as well. For example, creating a new health desk is like setting up a new institution, and there are multiple agencies which are in charge of the airport, like immigration, the disease control division, the Ministry of Home Affairs, which looks after the police and security personnel. And like every undertaking, multiple agencies have to be coordinated, and that is also not easy. And perhaps just like we do disaster drills or disease outbreak drills. In the future, we'll need to do simulation or drills to set up new offices or systems whenever there is a need. And right now, there is a crisis management procedure which is in place at the airport, and people are read a script by the crew of the aircraft before arrival. They have to fill public health declaration forms, which are online and filled online. If they haven't completed it, they can complete it once they arrive. And there's also a passenger locator form, because at the start of the pandemic, these forms were filled, but then the details, these are not easy forms to fill, and then it's hard to track passengers if they need to be tracked despite the fact that they fill these forms. Now, at the start of the pandemic, everyone's instinct was the airport could be the point of entry for disease, because Europe had started seeing a surge of cases and deaths in early March, and lots of travelers coming to Nepal from Europe and from the Persian Gulf countries. And once travel restrictions were imposed in Italy and then France and Spain, the Nepal government was also prompted to take preemptive measures. But airport closures have ramifications. They close the airport, but there are people who want to visit close family in dire circumstances. There are people who are abroad for healthcare reasons. For example, this is what a wife of a cancer victim said. Our son was scheduled to come back from abroad after his studies anyway. His father was diagnosed with cancer after the start of lockdown. It was already in an advanced stage when first detected. Before the flights could resume, he passed away. They were so close to each other. So complete closure of flights can have impacts on families like this. We had another family who had a cancer patient. We had been to New Delhi for treatment of his esophageal cancer. After the flight suspension, we waited for a few weeks. Then we reserved an ambulance, which brought us to the Nepal land border, and then took another ambulance to Kathmandu. So blanket closure of airports will have these ramifications, and we can't just view them as a point of entry for disease. There were other travel restrictions that were put in place. The first case in Nepal was in January 2020, a student from Wuhan, and in the 11th of March, the pandemic was declared, and soon after, schools were closed here. And on the 20th of March, flights and arrivals from 50 countries were stopped. Later in March, the second case, who was also a student from France, was detected. And then after that, land borders to India and China were closed. And on the 24th of March, there was a nationwide lockdown. The lockdown went on for a long time. It's not as simple as making a rule when you declare a land border to be closed, especially when Nepal shares a very long land border with India in the south, and there are multiple points of entry. In fact, you could say that there are infinite points of entry. And although a parallel lockdown was started the day after the Nepal national lockdown on the 24th of March, in India, they still allowed thousands of migrant workers to go back to their homes. And many migrant workers from Nepal go to India in search of work. And when such crowds of people return, you can imagine what will happen. This is the land border between Nepal and India. I was visiting family who live close to the border a couple of years back, and I just went for a morning run, and I was right next to a pillar which signifies the border between India and Nepal. and there is actually no fence, no checkpoint. You can just, if you know the way, you can just walk right through. There are rice fields on the other side. If you walk long enough, you will reach a road, not very long, maybe a few kilometers, and then if you and you'll reach the next village very soon. So people who live close to the border, they wouldn't be impacted by a border closure in such a situation. Sometimes there are desperate measures which need to be taken. And the border on the west of the country and the east is bounded by rivers, and people, although the borders were closed and the bridges would be sealed by security personnel, people could still swim. And ironically, this man who swam to reach his country was arrested as soon as he reached his home country, because the borders were supposedly closed. So the points to consider are: can you actually seal an open land border? Can you screen the returning migrants when there are hordes of migrants who are returning? And can you handle the returning migrants? Will you arrest everyone who crosses the land border or who swims across the river? Despite those obstacles, people were generally compliant, and then there was a compulsory quarantine which they had to adhere to. And quarantine is actually a quite socially acceptable option for most Nepalese, and people complied. There were many quarantine centers coordinated with a team of administrators, security personnel. The doctor who shared this picture with me is one of our former students. He's in the center here, Dr. Shiva Neupane. And people stayed in quarantine for 2 weeks, and initially they were tested before they were sent home to make sure they were negative. Then there's the problem of the stigmatized traveler. When the lockdown in India was imposed and the border controls were imposed, but they still allowed people to travel by buses to their home states or home countries. Many people came to the border and then they were stranded. And this is what a mayor of a rural municipality in the Nepal Hills told me. The people of my municipality were stranded on the border in the hot sun without food or water. They pleaded to me for help. I asked the bus operators for help. They denied because recently the fact that the virus even survives in steel and metal was in wide circulation, and they were gripped in fear. I eventually convinced a truck which carries rocks and gravel to help the migrants. Despite the bumpy ride back home on the back of the tripper truck, the returning migrants heaved so much thanks and praise to me for my kindness. So you can see the troubles that travelers had to face during the lockdown. And even the bus operators, although they were offered double the rates or triple the rates that they would normally charge for a trip, they denied because of the widespread fear that was there at the start of the pandemic. There was a sudden preemptive lockdown in Nepal when only 2 cases had been discovered in the country, and both were imported students coming in from high transmission areas. It was sudden, imposed one evening, and then the streets suddenly went quiet. There was great compliance to the initial lockdown. But as elsewhere, people in Nepal, they come to the bigger cities to work, and then when there's no work, the natural instinct is to go home. You can have a lockdown, but you cannot prevent everyone from traveling back when there's no vehicles or when there's no transport facilities. People still walk back to their homes. So people walked up to 3 days to get home, some people more, up to 7 days. And because uh, when there's uncertainty, they don't know how long their savings will last, and then it is better to uh, go back home where you don't have to pay rent, where it's cheaper to buy food rather than stay in a city where living expenses are high, but you don't have an income. Despite this, there was very little protests, and the lockdown was probably aided by a resilient and hardy people that the Nepalese are naturally. Not just the effects on travelers, there were also collateral health effects, as this prospective study, which was following up attendances and mortality rates in maternity units in uh, Nepal, showed that the number of people seeking maternity care and childbirth care decreased by almost 50% during lockdown, and the number of stillbirths and live births increased, although that increase would be due to the fact that people seek care for serious conditions more in such a situation, and if there's everything's normal, they tend to not seek care at a health facility. Now, we always ponder about the rationale for a national lockdown, and was it right to do a lockdown at that time? Probably it gave us time to prepare, time to set up labs or hospitals or isolation centers, and also gave our doctors and nurses more time to gain experience from other countries on how to treat the disease better. But if you look at this epidemic curve, this is a new type of epidemic curve in that there are two curves, the yellow lines showing the cases by date of diagnosis, but diagnosis always lags behind the date of onset of disease. So the greenish lines show, greenish bars show the date of onset of disease. And you can see that if on any given day you diagnose one or two cases on that given day in the community, if it's a community spread of the disease, there will be hundreds of cases literally which have already had their onset but are yet to be diagnosed and will be diagnosed at a later date, because there needs to be some time before the patient recognizes their symptoms and decides to go to the hospital, and up to 5 or 6 days before they present to the hospital. And this is the rationale probably for doing a preemptive lockdown. But in our case, it was a long time after the lockdown before the first community transmitted case was detected, and actually it was hard to figure out which was the actual first community transmitted case.
Amit, we'll have to rush you a little bit.
Okay.
We're running low in time.
Okay, so there's still speculation as to whether the lockdown determined this curve, the low rates initially, and the increase in rates actually happened after the lockdown was lifted. Now, when there's travel restrictions, can those in need be identified and helped? The socioeconomic circumstances differ for different people. For example, a trekking guide said she just decided to move back to her village because there is enough food, as the family is self-sufficient in agriculture. But others who live in the city, they have to rely on food handouts. There's something that a volunteer who feeds destitute and homeless people in Kathmandu said. She said that the cost price of one good meal is just about 35 rupees. So going by this number, for the price of one PCR test, you can actually feed someone 2 good meals a day for a whole month. So you have to balance the need for doing PCR tests versus the need for giving food aid to people in need if there is a lockdown. Was a complete travel ban rational? Well, there was a lot of data coming in, a lot of publications, especially from the experiences in China, and it showed that during the cordon sanitaire, which was the complete lockdown in Wuhan, actually decreased the number of travelers and also decreased the numbers of cases which were seen in other provinces in China. So we had a lot of experience from the data that was generated through the system in China. Can tourists, so about tourism, Nepal is still tepid about reopening for foreign tourists as the cases are still rising, but and anyone traveling here has to be in quarantine, get tested at the end of the quarantine period, but probably if they're going to a trekking destination, they can travel in a bubble, in a perpetual state of quarantine, just travel with the group and not meet with anyone. But that still hasn't happened yet. So this is the end of my talk. I just want to thank Dr. Ashish Loni, Dr. Deepak Paudel, and Sabina Ji, and Shiva Rajneupani for the quarantine pictures, and Nishant Thakur, who manned the airport help desk, for giving me the insights about what happened there. Thank you.
Thank you, Dr. Amit, for sharing your viewpoints and sharing the viewpoints of other people that were affected by the travel restrictions. I would like to remind audience that if you have any questions for any of the speakers till now, you may leave it in the chat box. With this, I'm pleased to welcome our next speaker from UK, Farah Shahi. Over to you, Farah, for your presentation.
Thank you very much for having me. As Sabina and Ashish say, my name is Farah. I'm an infection medical doctor in the UK. I'm going to talk to you about the effects of travel guidelines on the UK. So that's also my disclaimer. I'm not an epidemiologist, but I have been following this quite closely. So I'll start by talking about our first wave and the benefit of hindsight, and also now our second wave, and then finally conclude. So the 31st of December was our New Year's Eve, which was a shocker for more reasons than usual, in that the WHO announced this novel coronavirus from Wuhan, China. And originally our Public Health England testing guidelines, which told us who to test within the UK, were restricted to Wuhan and then eventually to Hubei province and then to the whole of China. But by the week beginning the 27th of January, we had our first 2 cases. And this was actually in my clinical training ground in Hull. And they make a point in their paper that they released that actually this was also because of the close unit that these patients were within. It was probably the first person-to-person transmission within the UK, although it wasn't acknowledged as such. But they also make the important point that because Public Health England were restricting who they would test based on clinical and epidemiological case definitions, applying those too strictly meant that those patients wouldn't have met the criteria for testing had Hull not asked them specially. And that's because PHE were at the time testing in their own central labs only. So by the 8th of January, we had a case of a chap who we think was the first Briton to be knowingly COVID positive, and he was known as the Brighton super spreader. So he was a businessman who went to Singapore and was completely asymptomatic and went on record as saying that too. And in a way, it was helpful to know that he was very asymptomatic because we were still debating it at the time, but it actually did nothing to alleviate Public Health England's concerns that this was a Far East Asian disease, essentially. And therefore, they expanded their travel guidelines and their testing guidelines to cover more of Far East Asia. But that's probably to our detriment, actually, because it was an oversight. By the 29th of February, we had our first official UK transmission, which was a man from Surrey in the south with no travel history. And by early March, Iran and Northern Italy were added to the highest risk areas, and we locked down on the 23rd. So everything was changing quite quickly, and I can't access now the guidelines that we had, but this is the closest I've got. So this was for the general public, and it was about travel restrictions, and it mapped quite closely to the people that we were told we should test. So category 1 are people who should self-isolate on return, even if they were asymptomatic. And category 2 were anybody who should self-isolate if they develop symptoms. Now you can see that this was withdrawn on the 13th of March, and I come back to this shortly, but this was even though we were starting to know that actually asymptomatic carriage was a potential, and you can see that it focused on mostly Far East Asia. There's a paper that I'm going to talk about in more detail in a little while, but I'm fairly left of a conservative government, so I don't obviously agree with them very often, but I do have sympathy for the fact that, as Amit was saying, it's very restrictive to obviously lock down borders, and that has a human rights implication. And this quote from this paper says it should not be more restrictive of international traffic and not more invasive or intrusive to persons than reasonably available alternatives that would achieve the appropriate level of health protection would achieve. But with the benefit of hindsight, we've managed to sequence the viruses that were picked up within the UK at the time of our epidemic. And this is very much, it's a genomic analysis, so it's not based on patient history at all. And one thing that they, or the things that they derived from this paper, were that international arrivals decreased significantly between March through to April. But this estimated importation intensity peaked at a point where the government had asked Britons abroad to return. So that was about the 17th of March. And this high inbound travel was associated with a peak in cases elsewhere throughout Europe. So they estimate that 80% of importations within the UK were between the 27th of February and the 30th of March. And that doesn't compare with local transmissions. This is just the genomic analysis of what was sequenced. But they found that actually the majority of cases from the UK were attributable to the similar variants that found in Spain and France, as opposed to Italy, actually. And those were the people that we were locking down to in Europe. And even then, we were only actually controlling northern Italy cases, not for the south of Italy. And this paper pretty much says the same thing. So this is a paper from the same group, but the Sheffield contingent. And they found that there's a more transmissible variant of the virus, which I'm sure you've heard about, which is the G614 mutation. And you can see that in March, predominantly it was D614 throughout Asia. And this G614 mutation really came about from Europe, and then being more transmissible has since spread globally. So the UK have tried to do their own post-match analysis, if you like, and the Home Office prepared a report. The Home Affairs Committee prepared a report where they state that, you know, the government wasn't on their own in terms of not excluding Spain early on onto our quarantine lists. However, between the 13th of March, which was when that travel guidance was withdrawn that I showed you, until the 8th of June, there were absolutely no border measures in place for the UK, which was incredibly unusual compared with other countries. And they state that thousands of cases from Europe came back between the 13th of March and that lockdown on the 23rd, because of the fact that the government were asking Britons to return, and likely contributed significantly to our first wave. They state that this idea that we've got now of travel corridors, where we list safe and less safe countries for travel, and we restrict essential and non-essential travel, is welcomed, as well as the acknowledgement that any travel isn't risk-free. However, these warnings on changes need to be as preemptive as possible so that people don't get caught out. And they also make the point that we need border testing, which I'm still not sure we actually have, to be quite honest. So we're unfortunately now well into our second wave, and these figures were from about half a week ago, and they're already a fair bit worse. I do a lot of science communication on Instagram, where I talk to people about the trends of COVID within the UK in particular. And one of the things I noticed is, as France's cases were increasing, we were, if you superimposed our curves on top of theirs, we were about a month behind their numbers. So I wondered if maybe, even though we actually restricted our borders to France when I think they had about 1,500 cases, whether actually travel between us and France had contributed to our wave. But looking at the data, this was published back in February, and they make the point that actually restrictions to travel from mainland China was sufficient to slow the spread of the disease, but it wasn't sufficient to actually contain it. And that actually this asymptomatic incubation period has probably been far more important than we've realized. And that paper that I quoted from earlier is actually a mathematical model where they compare the impact of travel with local transmission. So they were looking globally at 142 cases and using figures from May 2019 as a proxy for May 2020's restrictions. They found that actually imported cases would only account for less than 10% of the total incidence, and that the only places where restricting borders very heavily made a difference would be in places, for example, like New Zealand, where their local cases were quite small. So they state that travel restrictions have done little in most countries to change the course of local epidemics and might not be justified given the high economic and social costs. Now, this is very rough. It doesn't take account of population density or numbers per 100,000. But I decided to try and look, therefore, at when cases started to rise in the various countries in Europe associated when their local lockdowns lifted. So the UK restrictions lifted on the 23rd of June, and by the 12th of July, we had about 367 cases, which was our lowest point. By the 1st of September, though, we had more than 2,000 cases, and our schools don't start back until after the first week of September. And a lot of people were worried that schools would be a main driver, and I'm sure they haven't helped, but actually we were already peaking before then. France lifted their measures around the 15th of June, but by the 7th of August, so less than a month later, they had 2,000 cases per day. Spain again took only a month in order to get to that figure. And Italy, they took the longest, and I'll come back to that in a second, but they took until the 1st of October to reach over 2,000 cases. And it almost feels laughable now that the UK is restricting to Italy. I feel like Italy probably should have restricted to the UK. I'm not going to cover Germany because I believe the professor will talk in more detail about that. Germany obviously did very well in the first wave and unfortunately are suffering more in the second wave. But what I think is intriguing is actually it's probably more about our local guidelines than our border control guidelines in terms of the second wave. I think once the virus has essentially got into the country and had a foothold, it's likely that internal mobility is going to drive that transmission more. And it's things like this. You can't seem to get through to the government that countries that have managed to control their COVID rates have actually done better economically. And New Zealand is a really good example of that. So in order to try and help the economy, they offered in the month of August a 50% discount if you ate out inside a restaurant, and that included places that had very good drive-throughs like McDonald's that were working perfectly well. You would get money off if you went in to eat, which means taking off your mask, which means socializing with more people, which means more exposure. And I suspect that some of this has driven some of our peaks within this second wave, unfortunately. But in the last week or so, this paper's just come out. I think it was on the 28th of October. I haven't managed to read through it yet. They highlight another variant that they feel has emerged from Spain, which is now peaking within the rest of Europe as well. And its incidence is increasing. They don't know about whether it's more transmissible or not. They haven't gone into detail on that just yet. But it might be that, yes, internal measures do have the most effect, but clearly there's still a potential for importation. So I think it will be interesting to do the post-match analysis on the second wave actually as well. So in summary, I think travel restrictions are probably best applied when local rates are lowest, for example, in New Zealand in terms of border restrictions. There's not much explanation for what the UK was thinking really in mid-March to the 8th of June, but I think, to be honest, we'd probably already missed the boat by that point. Testing capacity and population density, cultural and behavioural differences make it really difficult to pick apart transmission dynamics. I mean, the UK and Italian populations, were they more nervous to mix again, given the number of deaths that we had, than the French or the Spanish? I suspect that might not be the case, but I'm sure cultural differences do make quite an impact. I think it probably is more about in-country mobility than cross-border mobility, but I do wonder if the UK has helped to drive what's happening in Italy, but it's, like I say, it's really difficult to pick that apart. So I think adding countries to the UK quarantine list at the moment might be a little bit after the fact, to be honest. I think everybody's probably better off protecting themselves, unfortunately, from the UK. So thank you very much for listening. Please try and stay safe and submit your questions. Thank you.
Thank you, Farah, for the very informative delivery. So without any further delay, I'd like to welcome Professor Dr. Tomas for his presentation. Over to you, Professor Dr. Tomas.
Hello. Thanks for inviting me for the presentation, and hello to everybody. Yeah, I've been asked to give some German insights and European perspective, and latter is really difficult because there are so many differences in Europe. So I try to go through the data I have, a few of them. This is a map that's known to all of you, I guess. And this is just the active cases right now. And when the whole thing started coming from China, and we had the first cases in Europe, everybody was saying that it's going to be a disaster in Africa, and hasn't been yet, and probably will not be. It's a bit puzzling, really, that some countries are affected heavily, and some are affected in very low numbers. In particular, in sub-Saharan Africa, we see very few cases. There have been various ideas why that is, but nobody really knows. So seems to have something to do with populations, with age of populations or things. We don't know. That's the global curve of cases, and obviously there are huge differences between different countries. So in particular in Africa, there has been a wave in some countries like South Africa, but by far not in all of them. And so looking at travel, it might be safer to travel to African destinations, for example, rather than staying in Europe. These are the last 2 weeks incidents, and the map has been darkening for Europe again. It looked much better 2 months ago. But again, there are quite a few countries that have very low incidence right now, so restricting travel globally seems to miss the point a little bit. These are the curves in Germany. We had the first importation, which is basically not visible on this curve, from China. There was a tiny outbreak in the south of Germany that was contained. And then the wave started with, during the skiing season, actually. It was party time for German tourists going to Italy and Austria for skiing, and they brought the cases to Germany. And was a transmission not really by travelers coming into the country, but by Germans gathering and having parties. And then came the carnival season that contributed highly too. So it was from the start not really travel associated in our countries, as in many other places really. And now we go through the second wave, which is actually a bit scary for many politicians in particular. And right now, I got a feeling they tend to overreact because they're trying to impose restrictions, example on travel, without having a clear concept what to do. This is the capital, Berlin, which has a clear increase of cases, but actually most of them are asymptomatic, or very low symptomatic. And that's a difference to the first wave, really. We saw a higher percentage of symptomatic cases at that time. Now we have patients in ICU, but right now it's only 12% of our ICU beds in Berlin are taken up by COVID-19 patients. So there's quite a bit of reserves left, really. And probably we can cope with much higher numbers because apparently most of our positives have no symptoms or very few symptoms right now. This is an interesting paper looking at the questions why the case fatality rate is so different in various countries, or has been at least. And they compared age of patients and case fatalities in different countries, and there seems to be a clear correlation really for most countries. So Germany was fairly lucky apparently because our cases were mainly in young people going for skiing, for example, people going to parties and so on. That's probably a reason, maybe the major reason, why we see fairly few severe cases compared to our numbers, whereas other countries like Italy had the misfortune that more older people got COVID-19, and therefore they had a higher case fatality. Apart from older age, there's other risk factors, and a major one is probably obesity. data from the US point into into obesity massively, and that may be the reason why we see less severe cases in the African continent. They're not as old and not as obese as Europeans in general. What we are doing for testing is PCR. That's the method that has been established, and that's what our politicians ask us to do. Problem with PCR is that it's actually not a screening method. It's not been devised for that. So we are testing many, many people with a fairly complicated method that's eating up a lot of resources. And we get lots of positives that are in the post-acute, post-symptomatic stage, and they still test positive by PCR because we detect every single RNA strain, but they are no longer infected. So what we need to do is really change our testing policy here and go towards antigen tests and other methods to get a more balanced view of people that we need to isolate and not test everybody positive who has had the disease in the past, for example, in the past 2 weeks. Good news is that people who had other corona infections, as you know, there are 4 other viruses moving around regularly during the flu season in Europe. They seem to be protected against severe causes of the disease. There's a good study here, and it's been published very recently, that shows that those who had previous infections by coronaviruses have a much milder clinical course and don't die in general, as compared to those who have to have first contact with a coronavirus. That again might be an explanation for differences in countries. And what we see is a huge amount of asymptomatic people. There's a variety of studies here on ships, in populations, in prisons, and so on, and a high percentage of people here, up to 96% here in prisons in the US, were asymptomatic. And that's of course good and bad news. Good news because many people seem to go through the infection without having major problems. So there's not a major burden on hospital resources. Bad news because these people can still infect others. Infections are caused mainly by super spreading events. We heard that before. A study from China here, from Hong Kong, showing that most people were infected or during events like here in a bar or during a wedding or a temple. And the same is true for Germany. With the outbreak starting in March, most of our cases initially were infected during carnival sessions. So people having a party in closed rooms, singing and yelling. That's the way to get it. Apparently, it's a very recent paper in Science here showing at the SARS coronavirus to spread across time, and it seems that most cases really we have right now are infected by these events. So it's households or congregated living or events, and it's not so much international travel anymore. It was the case at the beginning, of course, but it's no longer. So you can of course ask whether it makes sense to close borders and restrict travel and so on. In Germany, rules have been changed yesterday, actually. There was a major session at the parliament, and our chancellor decided that she has to lock down the country immediately from November 2nd, which is called light lockdown right now. So it's the usual distancing and face mask thing, plus no large gatherings anymore, or no minor gatherings for that matter. Closed restaurants, closed bars, closed social life basically. And a selected regional lockdown for cities or regions when the caseload is exceeding 150 new cases per 100,000 within 1 week. Our states have a large leeway for local variations, so they can impose stricter or less strict variations of this, but in general that's the new rules. And our national borders are controlled. Our authorities have defined risk areas in the world where we are supposed to take care or better not travel, and it's basically the rest of the world by now. Even those countries, for example, in Africa that have next to no cases are defined as risk areas for some reasons. And there's a travel warning for these areas. If you do travel there, you can do that, and you come back, you go into quarantine for at least 5 days. and then you can try to test yourself out of that. But if you don't, you stay longer. That's 2 to 3 weeks, depending on the region. And there's no real European perspective in terms of European policies. Every country is doing its own thing. For example, Denmark has closed its border to Germany now. Seeing that our cases increase, they try to protect themselves against German tourists and so on. Our most major problem really is that nobody knows what's going to happen next week or the next month. Rules are changing the whole time, and politicians try to react and get a feeling that they're slightly panicked, really. In some instances, rather more, like this guy from the Social Democrats who's asking for controls within private homes, whether people stay apart, which is very much imposing into people's lives, obviously. So what we do need is to test, and we do that a lot. We test we do about 1.5 million tests per day right now, PCR tests, which is of course increasing the number of positives too. And there is growing opposition. This is a paper which has been published day before yesterday by a broad coalition of German physicians and medical boards who say that the recent regulations are just overdoing things and have no real basis to fight against the virus. So they asked to lift the lockdown again and to lift the border regulations and work more on convincing people that they need to stay apart and so on, because infections are not transmitted from other countries, but they are caused by parties, for example. How to inform oneself, there's a website on travel in Europe, which is not bad, reopen.europa.eu, which tries to keep up with the local regulations for travel within the continent, but yeah, sometimes it's lagging behind because there's so many changes. There's the IATA map, which has been shown already. And in Germany, we have a tool, an internet tool, which where you can type in your country destination, and then you get the recent regulations and when they have been changed last. So that's the information we give to our travelers. And in the end, we all wait for the vaccine, which is probably, we assume that the first licensure will come in November already during EMA. And then the vaccines will become available probably during the winter in Europe. And then there will be something like a corona vaccination certificate, which will hopefully make movement and travel possible again. Thanks. And that's it.
Thanks, Professor Dr. Tomas, for your informative presentation. So with this, we'll move on to the Q&A session. I would like to request Dr. Asis to take a lead on this.
Thanks, Sabina, and thank you to all of our speakers for brilliant presentations, and we really did learn a lot. And I already have some questions. I'd start with some questions for Fernanda. One of the questions, Fernanda, is that where in Argentina are the people quarantined when they come into the country? Are they asked to quarantine in hotels, or is there some special places, or just they have to go home and take care of it themselves?
Well, first of all, it's important to emphasize that the first prevention is to take all measures to ensure that passengers are not sick when they get on the plane or when they come to the country. That's why it's mandatory that the passengers have the PCR before boarding. In respecting of the hotels in Buenos Aires city, for example, the government pays for hotels that are not working to isolate those who don't have the possibility to isolate themselves in their own home. But it depends on the cities and the places and the situation of the pandemic in that location.
And also the second question for you is, how is it managed, the social distancing inside the plane, for example, and how, for example, in the restrooms, how in the airport? This little details some of our participants were wanting to know.
Okay, thank you very much for the question. For business reason, it's not possible to maintain the social distance between seats because prices could be unaffordable. However, it is considered that because of the airflow, the air of a passenger with mask is directed downwards, not to the sides. That minimizes the risk. We must remember that there is always a risk that we call acceptable. Zero risk does not exist, so we must agree at what level of risk we could work. So the risk always exists, but because of the airflow, it's minimized.
Okay, so thank you.
The restroom.
Thank you, Fernanda.
Yes, okay.
The next question is directed to Amit, and one of our participants wanted to know that since you were also an advisor for the government, are you satisfied with the government work, and some things that should have changed, or some things that you want to that should have been done in a different way?
Yeah, there were so many advisors. It must have been true for all the governments in the world. And then those in government, they have to decide whose advice they want to listen to. If there are so many, then they must make a committee of advisors. And then once they decide who they want to listen to, then they must decide what they want to do quickly. And decisions take a long time to happen. It was declared, it was recognized that there was a problem in January itself, but then we still weren't decided about what to do until late in January. And then once you decide, like when decisions are made, they have to be implemented quickly. So there's a gap between who do we listen to, and then do we take a decision or not, and then from decision to action. So things have to move quickly in such a pandemic. There's no excuse for being indecisive. So I think one of the things governments could do better is be more decisive and look at all the options on your plate, and then it's obviously it's not clear which are the best options in such a new event. No country in the world knew what was the best thing to do from the start. But when there are multiple options, there are obviously a few sensible options, and then a few dubious options. You can exclude those. So I think the decision-making skills are important, and they could be improved upon.
Thanks, Amit. And the next questions, there are two of them related questions. I think they will go more to Professor Jelinek. One of the questions was the differences in waves. Is it a result of testing artifact? It's because when there's more widespread testing, there is a chance that you will also know more asymptomatic people. And is the second wave where there are greater numbers, is it because of more testing and catching those more asymptomatic people? And also I will like to add the next question to this, that another participant asked, is the lower incidence in Africa that you mentioned, is it due to less testing or because there is less cases? So maybe these two are a bit related, Professor.
Yeah, in general, the more you test, the more cases you find, obviously. I mean, you have just having false positive increases your caseload, obviously. But we are, as I said, we are using a very exact method with the PCR, which is also very expensive and time consuming for screening purpose. So we do right now is we detect basically everybody who's carrying just a tiny virus rest in his throat and testing positive, and testing more than 1 million people per day, obviously increasing positive rate. But we also see different strains circulating in Europe, as has been shown here in these presentations, and they might spread easier too. So it's not just more testing, it's also wider spread of the virus, obviously. It's true that in other countries, like in Sub-Saharan Africa, there's not as much testing as in Europe, but there is testing too, and still they see very few cases, and hospitals there are not overburdened by patients, and there's not an increase of case fatality or general fatality actually there. So it's obviously there are very few cases and very few severe cases in sub-Saharan Africa. It's not just not looking, it's just not happening there in many instances, and we're not quite sure why.
Thank you, Professor. Also, if there are any more questions, I'd like to ask the participants to put it forward. If not, then also one question I would like to get back to Fernanda. Is that there was one question that because the sophistications that you have shown that have been installed in the airports and all, is the government investing a lot, or has it caused an increase in the ticket prices for the planes and all? This was something one of our participants wanted to know.
Thank you very much. All the measures taken are paid for by the interested parties. For example, shops, the airport itself, the airlines. The tests are paid by the passengers themselves. In fact, the measures are always the same: distance, mask, cleaning of surfaces, and hand washing. For example, if an acrylic screen is not possible, a transparent plastic can be used. For alcohol, you can hand a plastic dispenser. To save money, you have to be creative. It's not a question of money always. On the other hand, some things are not longer used. For example, magazines printed on the planes or hot food. That also means costs to be discounted.
Okay, thank you. I think we are coming slowly to our 90 minutes of our allocated time. If there are any more questions, please, we still we can entertain a couple of them. I think one question to Farah would be that since you also work with a diagnosis of acute fever in low resource settings, and as we know, as we've heard, that all the testings they are expensive, and also this is one of the reasons that low-cost settings or low-income countries will not have a lot of testing, because they are also regulated by cost. What can be done when we know that there are so many strains that are coming up and spreading? What can be done to help the low-resource settings so that they can, I don't know, maybe a little better catch these cases earlier?
Yeah, thanks. So I think there are two things. One, they're not necessarily separate strains, which I think is a really important point to make, because a lot of people get very worried that having variants in the virus might mean that any vaccines that are created won't then be effective. So they don't necessarily act differently. It just means that we can work out their genomic variants enough to be able to pinpoint where they might have come from. I think in terms of testing, it was really good to see that the WHO had the antigen testing that's coming out for a fraction of a price, and I think unfortunately it's making sure that we make sure that that is delivered effectively to those settings that can't necessarily afford things like PCR. Within higher resource settings, there's moves to now have multiplex PCR testing. So within the UK, for example, we will test for flu as part of a multiplex rather than just singular diagnostic techniques. And that, I think, will make it far easier for a lot of laboratories in mid-resource settings as well.
Thanks. I think we went a little bit out of the topic in this question. Thank you to all of our participants for attending our webinar today, and also all of our speakers for really great presentations and really stimulating discussion in the end. In the end, I would like to also show one video that Amit had sent us about an ancient practice of self-isolation that has been practiced in Nepal for many generations. And with this, I would like to end our webinar for today. Thank you all for being a part of it. And those who want to stay and watch the video, I will leave everyone with the video playing in the background. I'll just, sorry, I'll just share the screen. Share the screen, sorry, okay.
Malaysia quarantine gaya chonla. Say kuda kena chona. Ukar international da asahaj time mujo. Anong thing ato kuna we be manon data. Naman dia jong bukan. Kuli inform jimak ke people dan data lah. Esa we banau lawe kangka malbian jong ka. Ada atmosfer ya maka thang kuna quarantine itu. Jisa, un apa ni sih dulu kani itu.
There are merchants, they were a courageous band of people. They suffered great hardships traveling across the Himalaya, and they had lived away from their families for long periods. They had a huge influence on the commerce and Buddhist art of the Himalayan region.
Jadi pertama ya kalau ini wabi cuping kani bi ni kan. Kalau wabi kaya jasa wabi semua wabi mereka. Jadi pertama ya, oke we ni Christmas सरकार orang dek tahu kau gato.
चिसो रोग लाग्थ्यो पानी भर्ने पानी रोग भन्छ त्यसलाई पानी रोगहरु त्यस्तो रोग लाग्नु भएर शरीरमै पानी भर्ने चिसो लागेर खुट्टा सुनिने छाती दुख्ने मुखी सुनिने यहाँ आउँदाखेरि केही रोग बोकेर आउँछ यहाँ पनि सर्छ उनीहरुले एडजस्ट गर्न सक्दैन भनेकोले त्यो ठाउँमा राखेर त्यहाँ 13-14 दिन राखेर उनीहरुलाई यहाँकै एडजस्ट हावापानी अलि मिल्न सक्ने भइसकेपछि अनि त्यहाँ थपिके भन्नेमा नुहाइदिएर शुद्धिकरण गराएर पनि बल्ल घर ल्याउने चलन सक्दैन।
When my father returned from Tibet in 1954, he had to live separate for 2 weeks. They had to get a note from the royal priest about the purification rites to allow them to return to society.
त्यहाँदेखि लासा जान्थ्यो हाम्रो हजुरबाको पनि बा पनि जुजुबा भयो जुजुबाको पालिदेखि जाने त्यो बेलामा अनि हामी सानो छँदा अनि असलमा चाहिँ असमृद्धिको नाममा त्यो ठुलो घर थियो बच्चा बेलामा हामीलाई राम्रो थाहा थिएन अनि हाम्रो बाहरूसँगमा हजुरआमाहरूसँग मसिनो बारमा जाँदाखेरि त्यो घर देखाएर हेर तिम्रो बा र लासाबाट आउँदाखेरि सिधै घर आउँदैन यहाँनिर राख्छ हेर नानी भन्ने देखाउनुहुन्छ है त्यो घरको नाउँलाई चाहिँ एटा चप्पा भनिन्छ इटा चप्पा भन्छ त्यो घरलाई अनि हामी सानोमा थाहा थिएन ल घरको नाम साम भन्दैन लासाबाट आउनेहरू यहाँ चाहिँ 12-13 दिनसम्मै राख्छ पछि मात्रै अनि हाम्रो घरमा ल्याउँछ भनेर भन्छ।
There was developed this quarantine system because they live in crowded urban environments. And in the days before modern medicine, staying apart was the only way to prevent infection.
Some of these
restrictions should be revived because there was a reason behind it.
I would go and then the last time working needs to find out about the day. So a last time working working supposed to next time where Suki next time where to Maru. Let's time no do Samaji do to be a booker. She's a Overlumone and them are to them yoga.
Who owns history? Who did?
Thank you, Sabina.
I guess the video ended. So at the end, I would like to share one more information to our audiences. It's that we have more of this webinar in the upcoming months. We plan for the webinar on diagnosis and treatment of COVID-19 cases, practices, evidence, and lesson learned in November, and similarly on December for health system and COVID-19, and we may plan for other potential topics in near future. So you may visit our CIH website for the announcement. So thank you everyone for joining us in today's webinar. All the PowerPoints and webinar recordings will be made available in our CIH website. Thank you everyone, stay safe.
Thank you.
Yeah. Thank you all the speakers for your time and effort you took to share your presentations. Thank you all the audiences for attending this webinar today. We hope to see you in next webinar. So with this, I officially would like to announce the end of this webinar. Thank you.
Thank you.
Thank you, Sabina. Thank you, Ashish. Thank you, everyone.
I have one more participant here.
You may stop the recording now, I guess.